We're all in the ICU, septic shock. Always is a high stakes environment. You want to do as best as you can, as fast as you can. But I think inevitably, if someone's not responding as quick as you want to, someone on the team, resident, fellow, APP, pharmacist, may say, what about methylene blue? So our purpose today is to talk about that. When do we actually reach for it? And what does the current evidence say?
So methylene blue, for the background, is a nitric oxide cyclic GMP antagonist. People will say casually that it's a free radical oxygen scavenger, like that you have oxygen-free radicals and it's helping scavenge them. That's not quite exactly right, but by working on this nitric oxide and cyclic GMP pathway, we are removing excess nitric oxide, which we know happens during vasoplegic sepsis and profound vasodistributive shock. So by decreasing that, we think we can help reverse some of that profound vasodilation.
Some quick hits on what you just mentioned. Methylene blue can increase MAP by about 1 to 10 millimeters of mercury. Some have found that it can shorten total vasopressor duration up to roughly 31 hours. This was just from one meta-analysis study. As you mentioned, Furf, right, not thinking about it, but this P to F ratio, there's been a small bump in P to F ratio. And then two things that we're looking at, two primary outcomes that we should be looking at in large studies. What about hospital stay and what about mortality? So possibly a reduction in hospital stay up to 2 days. And some pooled data has looked at methylene blue potentially causing lower short-term mortality. But again, the caveat that these studies, there are a lot of heterogeneity, inadequate number of studies.
My process is usually to do a bolus and then see if I think it worked, that I will go for a methylene blue infusion. So to sum it up, methylene blue is mechanistically rational for patients with refractory vasoplegic septic shock, and you're acting on that nitric oxide pathway to decrease vasodilation. It can raise MAP and reduce other vasopressor requirements. This seems to be the most consistent effect in some of the studies that we have talked about. Effects on mortality and major outcomes are variable, remain very low certainty at best, possibly some positive impact. Generally, we think this is safe. You should be talking with your ICU pharmacist when you're giving it, and you should be monitoring for some of the major side effects that we talked about. And this is firmly a rescue therapy that is not part of standard sepsis management.
Absolutely.